This will be part 6 of the Neurolocalization lecture series, which will focus mainly on the segmental spinal cord reflexes, which I will just call reflexes from here on out, but other parts of the neurologic exam that do not fit nicely into other categories will also be included here. For the reflexes, there are 4 in the thoracic limb that are often described, 5 in the pelvic limb, and 4 other terms to be familiar with: the cutaneous Trunzi reflex, perineal reflex, Babinski reflex, and crossed extensor reflex. The most reliable reflexes are underlined and bolded. This means in the thoracic limb, only the withdrawal reflex is reliable, and the only reflex we will go through in detail, but in some of the neurologic exam videos you will see how to perform the other reflexes. In the pelvic limb, the withdrawal reflex and patellar reflex are largely reliable. However, in older large breed dogs without any neurologic or orthopedic abnormalities, the patellar reflex could be absent. Lastly is the perineal reflex, or sometimes referred to as the wink reflex, is another fairly reliable reflex. As important as reflexes are, there are a few things to keep in mind. First, an animal needs to have more than a reflex deficit in order for there to be concerned for a neurologic abnormality. If an animal presents and does not have a withdrawal reflex, but the remainder of the neurologic exam is normal, this means you either did the withdrawal reflex incorrectly, or there is another reason for the withdrawal reflex being abnormal, such as an orthopedic injury which results in pain when the animal flexes their limb. It is also important to keep in mind that it is the movement that we are evaluating for in a reflex, but the afferent portion is just as important. The first reflex we will discuss is the patellar reflex. This is where we strike the patellar tendon with the flat part of the reflex hammer. This results in a stretch of the Golgi tendon organ which results in depolarization, and the signal is propagated through the axons of the Golgi tendon organ forming part of the afferent portion of the femoral nerve, ultimately through the spinal nerve, and then the dorsal nerve root, and into the intumescence of the L4-L6 region. This signal is then propagated through the ventral region of the gray matter, then through the ventral nerve root, through the spinal nerve, to the femoral nerve, then the neuromuscular junction, and ultimately to the quadriceps muscles themselves. This excitation of the quadriceps results in flexion of the muscle and extension of the stifle joint, raising the distal limb, causing the classic kicking motion we think of with the patellar reflex. Because only one synapse occurs between neurons in this pathway, the patellar reflex is known as a monosynaptic reflex, or sometimes called a myotatic reflex. The withdrawal reflex was gone over in a previous lecture, but we will go through it again because that was a while ago. This is a polysynaptic reflex, meaning interneurons are involved, and is a much more complicated reflex compared to a monosynaptic reflex. Therefore, we will go through it on a superficial level to try and avoid confusion. It starts, as expected, by pinching a portion of the distal limb, typically a toe or webbing between the toe. That depolarization is then propagated up the nerve, through the spinal nerves, then through the dorsal nerve root. Within the spinal cord, that signal is then sent to interneurons, which is different than the patellar reflex. These interneurons can either communicate with the contralateral side or the ipsilateral side. This contralateral communication will come into play later. However, for now, we will focus on the ipsilateral side. That signal from the interneuron will then propagate to the ventral region of the gray matter to the lower motor neuron, whose axons form the ventral nerve root, the spinal nerve, then the nerve itself, which ultimately causes flexion of the limb. Again, this is a local reflex arc and has nothing to do with conscious perception of pain. The withdrawal reflex is further complicated in that more than one nerve is involved in the reflex. Going back to the patellar reflex, the afferent and efferent were the femoral nerve. For the withdrawal reflex in the thoracic limb, the afferent is determined by where in the limb you are pinching. If it is the dorsal region of the distal paw, the radial nerve is stimulated. If it is the ventral region or lateral, it is the ulnar nerve that is stimulated. And if you pinch a little higher on the medial aspect of the limb, the musculocutaneous nerve is stimulated. On the efferent side of things, the flexor muscles are stimulated. So for the carpus, it is the median and ulnar nerves. For the elbow, it is the musculocutaneous nerve. And for the shoulder, it is the axillary and suprascapular nerves. Another thing to consider with the withdrawal in the thoracic limb is that it assesses almost the entire intumescence, or C6-T2 region. As a general rule, the more proximal the muscle on the limb, the more cranial in the intumescence the nerve is, and the more distal the muscle or sensory region is on the limb, the more caudal in the intumescence we are evaluating. That is why we are evaluating each joint when we perform the withdrawal. If, for example, the carpus and elbow flex well, but the shoulder does not, this could indicate a more cranial, or C6, C7 lesion. The myotatic or monosynaptic reflexes in the thoracic limb are not reliable, so we will not discuss them here, but if you are interested in which nerve is involved for each reflex, they are listed on the screen, so feel free to pause here. For the pelvic limb, the withdrawal is a little more complicated with the afferent. However, the same principle applies where the more distal we are in the limb, the more caudal the nerve arises from the intumescence. Starting proximal, the saphenous nerve, which is branch of the femoral nerve, is the main sensory for the medial aspect of the limb. The sciatic, which is actually just the combination of the fibular and tibial nerves, is lateral and caudal sensation around the level of the stifle. In the distal limb, as the sciatic nerve separates, the fibular nerve is sensory of the dorsal portion of the limb, and the tibial nerve is the caudal portion. If you look at the medial aspect of the distal limb, however, you will notice there is overlap between the saphenous nerve and the fibular nerve. As a general rule, we consider digits 1 and 2 sensory regions as being part of the saphenous or femoral nerve. However, this can vary from patient to patient. Despite this variability, we typically will test sensation or deep pain in the medial and lateral digits, so we can assess both femoral and sciatic nerves. As far as the efferent portion of the withdrawal reflex, hock flexion is provided by the tibial nerve, stifle flexion the sciatic nerve, and hip flexion by the femoral nerve as it innervates the iliopsoas muscle. Just like with the thoracic limb, the more distal in the limb, the more caudal in the intumescence the nerve will arise. For this reason, we need to be thorough with the withdrawal reflex evaluation and ensure each joint flexes when the withdrawal reflex is performed. If there is a lesion to the intumescence and withdrawal is absent, try either the lateral portion or medial portion of the distal limb, as the afferent portion varies. And just like in the thoracic limb, the withdrawal reflex evaluates the majority of the lumbosacral intumescence. A cranial lesion might just affect hip flexion, which could be subtle and easily missed if you are rushing through the exam. There can be other clues of sciatic dysfunction other than just reflex deficits. One example, as what is seen in this patient, is muscle atrophy of the caudal thigh muscle, like the semitendinosus and biceps femoris. Other times animals could have a crouched posture in their gait without any proprioceptive deficits. This could sometimes get confused with polymyositis as they can look quite similar, but again, sometimes we see this gait with lumbosacral disease. Another potential exam abnormality is a dropped hock. The fibular nerve is responsible for extension of the hock, so if there is more fibular nerve dysfunction versus tibial nerve dysfunction, a dropped hock could result without other deficits. This is a common abnormality too for neuropathies, like with diabetes. In other words, just like with the crouched posture, the dropped hocks are not specific to sciatic dysfunction but could be a clue in the localization. This gait, however, is a very classic tibial nerve dysfunction, and when it is bilateral typically indicates either lumbosacral disease or a polyneuropathy. This dog is not able to flex their tarsi, therefore this dog has learned to flick their limb forward in such a way that it will flip their paw forward, and they will be able to support their weight because there is still some degree of fibular nerve function, which is responsible for tarsal extension, and the femoral nerve still functions, which is responsible for stifle extension. This video is in slow motion, so the gait is easier to appreciate. As stated earlier, only the withdrawal and patellar reflexes are reliable in the pelvic limbs, and sometimes the patellar reflex is not in older large breed dogs. The other monosynaptic reflexes are not reliable. For those interested, to perform the sciatic reflex, you should feel the sciatic notch, which is between the ischiatic tuberosity and greater trochanter. Keep your finger in this notch and strike your finger. If intact, this should result in extension of the hip, stifle, and tarsus. The cranial tibial is performed by striking the muscle belly of the cranial tibial muscle. This should result in flexion of the tarsus. It is worth noting that in some studies where there is transection of the lumbosacral plexus, the cranial tibial is still present, which just highlights the unreliability of this reflex. The same is true for the extensor carpi reflex in the thoracic limb with brachial plexus transection. Grading the reflexes is different than the cranial nerves and proprioception, as it is done on a scale of 0 to 4. Just like before, 0 is absent, 1 is decreased, and 2 is normal. However, reflexes can be increased or even have a repetitive movement, known as clonus, just after stimulating the reflex just once. This is a sign of an upper motor neuron lesion, which is a nice segue into some other terms to be familiar with, the crossed extensor and Babinski reflex. When an animal is standing, normally crossed extensor is present. So, if the withdrawal reflex is stimulated, that signal travels up the limb, just like before, through the dorsal nerve root, through the interneuron, and down the ventral nerve root, which then causes flexion of the limb. However, some of the interneurons which communicate with the opposite side of the body are also stimulated. This then communicates with the extensor muscles, which causes extension of the opposite limb. This makes sense in a standing animal so they do not fall over, such as if they were to step on a thorn. Normally, when the withdrawal reflex is performed, however, the patient is in lateral. Because the patient is in lateral, the forebrain, which is the upper motor neuron, sends inhibitory signal to the limb that is opposite in which the withdrawal is being performed, because now that the patient is lateral, crossed extensor is not needed. However, with an upper motor neuron lesion, this inhibitory signal is lost, causing the crossed extensor to be present. So, a crossed extensor simply means there is an upper motor neuron lesion present, and it generally indicates chronicity. However, this does not always seem to be the case, and I have seen it with acute myelopathies. The Babinski reflex should normally not be present in an adult animal, but when it is present, it means the same as crossed extensor. To perform Babinski, we usually will use either the end of the reflex hammer or hemostats to scrape the ventral metatarsal region, and if you see the toes extend, this would be a positive Babinski. Both crossed extensor and Babinski are not sensitive, in that just because they are not present doesn't mean there is not an upper motor neuron lesion. However, when they are present, it helps you be more certain of an upper motor neuron lesion. Other parts of the neurologic exam to perform are evaluating anal tone and the perineal reflex, sometimes referred to as the wink reflex. Anal tone is just something that you can observe, although sometimes it is easier to appreciate when a rectal exam is performed. For the perineal reflex, we generally will do a gentle pinch in the region around the perineum to see if there is a wink present. This is a sensitive area, so please do not fully clamp down on the hemostats. The pudendal nerve is responsible for the afferent and efferent of the perineal reflex and anal tone, and arises from the S1 to S3 spinal cord segments. Something to note, crossed extensor, Babinski, and perineal reflex are graded as either present or not, meaning we do not give a numbered grade to them like the other reflexes. There are just a few items left worth discussing on the exam. First, the cutaneous truncee reflex. The afferent portion of the cutaneous truncee arises from each spinal cord segment, and the efferent arises from the C8 to T1 spinal cord segments, which is the lateral thoracic nerve, and it innervates the cutaneous truncee muscle. Like with many other segmental spinal cord reflexes, the cutaneous truncee is not the most reliable and should be interpreted in light of the rest of the neurologic exam, meaning if you localize an intracranial lesion and find that there is a cutaneous truncee cutoff, this should not change your localization. Similar to the crossed extensor, cutaneous truncee is helpful in increasing our confidence in neurolocalization. For example, if you localized AT3, L3 myelopathy, and there is an L1, L2 cutaneous truncee cutoff, we can be more certain of AT3, L3 myelopathy. Something else to know about the cutaneous truncee is that there is cross-communication to the contralateral side. So when one side is stimulated, both cutaneous truncee muscles should contract. However, in this example, we can see that the cutaneous truncee on the left is completely absent, but the right works regardless of which side is pinched. We can also see that there is muscle atrophy of the left thoracic limb. In patients with C6, T2 lesions, the cutaneous truncee reflex may be completely absent because the lateral thoracic nerve, which arises from the C8, T1 region, is affected. So, in this patient, we were concerned about a left-sided C6, T2 myelopathy, and the cutaneous truncee collaborates with our suspicion. Because the cutaneous truncee reflex leads to confusion a lot of times, we will go through it in a little more detail. When the skin is pinched, this will activate the cutaneous branch of the respective spinal cord segment, as shown in blue. This neuron will then send that signal to the spinal cord, which is shown here in purple, which then synapses with the lateral thoracic nerve in the C8, T1 region of the cervicothoracic intumescence. That signal then propagates down the lateral thoracic nerve, which causes constriction of the cutaneous trunci muscle. It is also worth noting that the cutaneous branch traverses caudally approximately 1 to 2 vertebrae, meaning if the cutaneous trunci cutoff is at L1-2, then the T13 or T12 spinal cord segment is likely affected. So now in this example, we can see that there is a lesion in the T13, L1 region. If we pinch the skin caudal to the lesion, the cutaneous trunci will be absent, and we will pinch roughly at each spinal cord segment until we finally reach an area that is cranial to the lesion, and that signal is finally able to propagate, and the cutaneous trunci reflex is present. Once the reflex is present, we can stop, and we do not have to keep pinching the animal. So in this example, we would say the cutoff is at T13, L1. Next, we will discuss checking for pain on spinal palpation, often referred to as hyperpathia. Within the thoracic and lumbar spine, this is best evaluated by applying pressure lateral to the spinous process, in between the spinous processes as shown on the image. Remember that the foramen is where the nerve roots are exiting, and if there is impingement of the nerve roots, this is quite painful. The easiest way to try and apply pressure to these nerve roots is at this position. Within the cervical region, we generally do not assess hyperpathia from the dorsal region, but rather we will apply pressure from lateral to medial at the level of the transverse process. The other way we will assess hyperpathia is with cervical range of motion. A dog and cat should be able to touch their muzzle to the side of their body. However, in some older animals, this degree of flexibility is not possible. Generally, if you are able to get past 90 degrees flexion on each side, there likely isn't clinically significant hyperpathia, but once again, there are always exceptions to this rule. Another term to be familiar with is hyperesthesia. Hyperpathia is when pain is induced with less force than what would typically be expected to cause pain. If you have ever had a bad massage, you can relate to this. A normal massage should not really cause pain, but with enough force it could. However, if you are painful, the force of a normal massage is agony. Hyperesthesia is the presence of pain when there shouldn't be. This patient is a good example where there is pain and abnormal sensations occurring just from walking around. And unless you have suffered an injury, walking should never be painful. Last, but certainly not least, is deep pain, or sometimes referred to as nociception. This should not be confused with withdrawal, as we are looking for a behavioral response with deep pain, and not the flexion of the limb. Nociception is hugely important in paralyzed patients, but if an animal still has obvious motor, there is no need to check nociception in most cases. Be certain to use hemostats that are properly sized for the patient when assessing nociception, and never use needle holders. Sometimes we will start with our fingers rather than hemostats because hemostats can cause tissue damage, so please keep that in mind. Superficial pain is difficult to differentiate from deep pain and is generally not assessed. This is the end of the neurolocalization lecture series. The next video will be examples of neurologic exams. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.